Dr. Rahul, I think we can begin. We have 125 participants in.
Okay, we'll start. Yeah, fine. Yeah, good afternoon, everyone. Welcome all to the fine afternoon webinar session. And today we had an interesting topic, syndromes of transient amnesia. We all know the permanent amnestic syndrome, which are relatively very well described, like limbic encephalitis or the classic one, that Wernicke-Korsakoff syndrome. But syndromes of transient amnesia, where the causes are still debatable and the syndromes are still yet to be defined very properly. So to throw more light on this topic, we had an authority on the subject, Dr. Christopher Butler, who is a senior clinical lecturer and honorary consultant neurologist at Imperial College London. He's a cognitive neurologist. His PhD topic was based on transient epileptic amnesia syndromes. So it will be interesting to learn from him about the syndromes of transient amnesia. Over to you, Dr. Butler.
Thank you very much indeed for this very kind invitation to participate in your meeting, in your program of educatory seminars. I'm really grateful to the Foundation for Indian Neurology Education for the invitation. So as was just mentioned, I'm going to talk about a few syndromes of transient amnesia, describing some of the clinical features to help you identify these properly in clinical practice, and a little bit of recent research on each of them as well. So the three syndromes that I'm going to be focusing on are these. First of all, psychogenic amnesia. Secondly, transient global amnesia. And thirdly, transient epileptic amnesia. And I'll explain about each of these as we go through. So first of all, psychogenic amnesia. Now there are two principal forms of psychogenic amnesia that are recognized. And the first of these is psychogenic fugue. And this was first really recognized back in the end of the 19th century in Europe. And there's a lovely book shown here by Ian Hacking, who's a philosopher of science in Canada, called Mad Travelers, about this epidemic of psychogenic fugue that occurred in Europe in the end of the 19th century. He describes in particular a man called Dada, who's a semi-literate gas fitter from Bordeaux in France, who was normally a timid and abstemious and modest man who had recurrent episodes whereby he would suddenly have profound symptoms of headache and anxiety and sweating, and then suddenly set out with a bag and travel for a number of days without remembering apparently where he had come from or who he was. And this seemed to catch on, and there were a lot of people who seemed to be doing this at the end of the 19th century in India, in France, and there was a big debate between Charcot and others about the etiology of these patients, whether this was a form of hysteria or a type of epilepsy. And then really it seemed to disappear from the literature through most of the 20th century until it became recognized finally as a fugue state in DSM-3 in the early 1980s. And nevertheless, there have been, recurrent cases described, particularly in the tabloid press. The famous English author, Agatha Christie, at one stage back in the 1920s, disappeared from her home in Berkshire and was found a number of days later in a hotel in Harrogate in the north of England, where she had signed in under the name of her husband's lover, which was something she had just discovered about. And she then had this period where she seemed to forget who she was and where she came from, and then went on a tour of the United Kingdom, ending up in a long way from home. There are still cases of this that are beloved, both of the tabloid press and also of Hollywood. And there are many movies that describe patients who have this urge to travel, and also this loss of personal identity that seems to go along with fugue state. The other form of psychogenic amnesia, which is recognized, is focal retrograde amnesia. And this is slightly different, and I'll describe the case of a patient who I came across a few years ago. He was a 53-year-old furniture salesman who was found in his car in a lay-by by the police on a hot summer's day, and they thought that he was had sunstroke because he seemed to be acutely confused. He didn't know who he was. He didn't know anything that seemed to have happened recently, and couldn't find his way home. So he was taken to hospital and had a number of investigations. And interestingly, it seemed to be a focal problem with retrograde amnesia, that is, remembering things from the past. He was able to learn new information. So he remembered that the police had picked him up in this lay-by. He remembered the doctors and nurses who attended him in hospital. And he had a lot of investigations, MRI scans, EEGs, and so forth, and these all turned out to be normal. And gradually he seemed to learn who he was again, but that depth of loss of personal experience of the past persisted. In fact, it persisted for many years and was very challenging for his family and himself to cope with. Eventually, it turned out that people realized, the medical people attending him realized that he had had some major psychological traumas in the months prior to the sudden onset of focal retrograde amnesia. There had been serious problems with one of his children. He, in fact, it turns out, had had a couple of prior suicide attempts in the past. And then just shortly before the acute episode, he had won £180,000 in the national lottery, and had then, in a fit of spending, spent it all and a lot more, and had ended up in a serious state of debt. His brother had then died. He had had his house repossessed, and all of this seemed to contribute to the sudden onset of his transient amnesic state. And as you can see in this graph here, when we asked him about memories from the recent past here, he seemed to be fine for all memories just prior to just after the onset of his acute illness, but all memories in the more distant past seemed to be lost. He then underwent a treatment with hypnotherapy and dramatically improved, and we seemed to regain a lot of his memories for the past. But this loss of autobiographical memories persisted, as I say, for many, many years. Now, these cases have been very sporadic in the literature, and but very recently, Michael Kopelman from London describes a series of 53 cases that he has seen over a number of years at St Thomas's Hospital, and did a really nice retrospective of them that was published in Brain. And he classified these cases into patients who had this fugue state, patients who had focal retrograde amnesia, and patients who seemed to have a mixture of the two. So they began with a fugue state of traveling, and then they seemed to recover their personal identity memories, but still have a loss of autobiographical memories for the more remote past. And he compared these patients to 21 neurological patients who didn't have psychological cause for their amnesia, so herpes simplex encephalitis, patients who had had hypoxic anemia, patients with Alzheimer's disease, and as well as 14 healthy controls. And he looked at the features of the amnesia. So, for example, over here, you can see that psychogenic amnesia patients are in the dark colored bars, whereas neurological amnesia are in the light gray bars. And psychogenic amnesia patients had a much more frequent loss of personal identity, not knowing what their name was, where they were from, other salient features of their past, whereas that was not present in organic neurological amnesia. Similarly, psychogenic amnesia patients failed to recognize family members in at least 50% of cases, whereas that was very rare in neurological patients. And looking at patients' background and psychosocial factors, A neurological history was clearly much more common in those neurological patients compared to psychogenic amnesia patients. But interestingly, a past or a precipitating head injury was more common in psychogenic amnesia patients. So this seems to act as a trigger for these psychogenic amnesia episodes. And in the past, it is much more common indeed in over 60% of patients with psychogenic amnesia. There's a history of depressive symptoms, whereas that was present in only about 15% of neurological patients. And there were a range of other things that they investigated, particularly forensic problems seem to be uniquely associated with psychogenic amnesia. Financial and employment problems were common, and substance or alcohol abuse more common as well. Now, the graphs over here show a study of autobiographical memory, that is memory for salient, personally experienced events in the past, in healthy controls and in the three groups of psychogenic amnesia patients that Dr. Kokelman looked at. And what you can see here is this more preserved recent memories, and whereas the past memories are more severely affected. But what you can see is that subsequently, over time, this is with follow-up, the patients improve, especially those with fugue, but also those who had focal retrograde amnesia. And in fact, this is much more heartening than the neurological literature would suggest, where in the past it's been thought that psychogenic amnesia actually had a very bad prognosis, and these results actually reveal a more favorable prognosis than the literature would suggest. So the underlying mechanisms for psychogenic amnesia are complex and not well elicited, given particularly that it's such a rare condition. And of course, there are levels of explanation for the condition, levels of explanation taking into account more psychological language or more neurological language. So, for example, talking of dissociation or of fleeing the past, conscious versus unconscious suppression. These sorts of explanations emphasize psychological triggers and the past, whereas more neurological explanations take into account interesting patterns of brain activity abnormality that have been shown in these patients. And over on the left here, you can see a study representative of a phenomenon in healthy subjects, whereby one can suppress one's own memories if instructed to do so. The paradigm here in healthy subjects is called the think-no-think paradigm, and participants are learn a series of words, a list of words, and then then in a subsequent experimental block, they are told either to forget or to try and recall individual words. And it turns out that that has a striking effect on people's subsequent ability to remember those words. The words that they intentionally suppressed are later much less able to be recalled. And interestingly, those words that are suppressed are associated with an increase in activity in dorsolateral prefrontal cortex, and a decrease in activity in the hippocampus, one of the key memory structures. So this is the idea behind this, is that you're intentionally using your dorsolateral prefrontal cortex to suppress hippocampal activity and suppress where the memories are stored. And in a couple of case studies of psychogenic amnesia, very similar patterns of activity here, shown actually with PET imaging, are evident. So these are two distinct patients here, and they also show an increase in activity in the dorsolateral prefrontal cortex with suppression of medial temporal and particularly hippocampal activity. So this takes us on to the organic amnesia syndrome and the neuroanatomical basis of this, because prior to the 1950s, it was thought that memories were widely distributed in the brain and that no particular part of the brain was responsible for memory function. And it was only with the striking case of the patient HM, who I'm sure many of you will have heard of and has really become one of the most famous patients in the neurological literature, that people started to realize the importance of the hippocampus for memory. So HM was a child when he began to suffer from epileptic seizures that were emanating from the hippocampus. And in his mid-20s, he had a surgical operation performed by William Beecher Scoville to remove the hippocampus bilaterally. And that had a very impressive effect on his seizure frequency and seizure severity. But unfortunately, it had a very dramatic effect on his memory. These are pictures from the paper in the Journal of Neurology, Neurosurgery and Psychiatry from 1957, indicating the surgical approach. What it turned out to be the case was that HM suddenly was unable to take on board new information. So he was in the hospital after his operation. He was unable to find his way around the ward. And when he left hospital eventually, he became lost in new environments. He was unable to recall what had happened earlier in the day. He was unable to remember new people that he had met. But despite this, his language function, his appearance, his personality, and many other features of his cognitive function seemed to be intact. So this was really the first indication that the hippocampus was a crucial area for memory function. Here are some MRI scans from much later in his life, after MRI had been invented, showing the absence of the hippocampus bilaterally in HM, whereas in a healthy subject, here it is. And this is a sort of close-up histological picture of the hippocampus, the anatomy of which is now well understood and the connectivity has been well studied, particularly as a result of the striking findings from HM. And there are a couple of things that I want to pull out that are going to be important for our understanding of transient amnesic syndromes. So from HM, we really learned these two key things. First of all, that there is not just one type of memory. Memory is divided up into a number of different systems, only some of which are affected in hippocampal amnesia. So first of all, there is the distinction between short-term memory or working memory and long-term memory. So short-term memory is the ability to keep online in your memory information for a short period of time, such as recalling a telephone number that someone has just given you whilst you type it into your phone, or keeping numbers in mind as you try and do a sort of mental arithmetic task. With working memory, very soon after your attention has been distracted to something else, those memories, that short-term memory seems to empty. And indeed, HM's short-term memory was intact, apparently, and the same as other people who had got normal hippocampal function. So it's not thought that short-term memory depends upon the hippocampus, at least not to a large extent. Long-term memory, on the other hand, in HM was very much disrupted. And it was particularly declarative memories, what are known as declarative memories or conscious memories or explicit memories, things that you can talk about, you can describe from either from your past or from your store of semantic knowledge about the world, so either episodic or semantic memories that seemed to be impaired in HM. Whereas non-declarative memories, that is memories for skills such as how to ride a bicycle, how to I don't know, how to make a cup of tea, things like that, seem to be intact in HM. So these are not thought to be dependent on the hippocampus, but instead on other regions of the brain, such as the basal ganglia, cerebellum, motor cortex, and so forth. The other thing about memory that we learned from HM, the key thing about memory we learned from HM, is that memories do not stay the same over time once they've been acquired. So over here on the left, you can see a graph of HM's memory for the past after his operation. So his operation was here in 1953. And as you can see, his memory strength for things that had occurred after that operation was very poor. He had what's called an anterograde amnesia, unable to take on board new information. Whereas his memory for very remote events, things from his childhood, for example, seemed to be much better or even intact in some cases. And then there was a period of a few years just prior to his operation where some of the memories seemed to be present and other memories did not. So the idea here seems to be that recently acquired memories are dependent on the hippocampus, whereas remote memories are not. And the thought is that initially, as you acquire a memory, it is the bits of the brain that are involved involve both nodes within the hippocampus here and modules in the neocortex. For example, the visual aspects of the memory represented in the visual cortex, the auditory aspects of the memory represented in the auditory cortex, and so forth. And all of these nodes are linked together by certain indices in the hippocampus. But over time, perhaps with rehearsal and what we call consolidation of that memory, the cortical nodes that substantiate that memory are become connected to each other and thus don't depend anymore on the hippocampus. You can then recall that memory without the intervention of the hippocampus. This process is known as memory consolidation, as I said. So how does this inform our understanding of these syndromes of transient amnesia? Well, first of all, for example, the case of transient psychogenic amnesia that I described earlier on doesn't really fit this pattern of memory consolidation, because as I mentioned, the acquisition of new memories seems to be intact, whereas remotely acquired memories, the acquisition of new memories seems to be intact, whereas remotely acquired memories, autobiographical memories, seem to be impaired. And that's the opposite that would be expected from our understanding of hippocampal function. So that is a strong indication that a memory, an amnesic syndrome is psychogenic. On the other hand, the syndrome of transient global amnesia, which was first described again shortly after, in fact, the case of HM was first described. So this was the first case of transient global amnesia was described in 1960. The format of this syndrome is illustrated by a patient I met a few years ago, who was a 56-year-old primary school teacher on school holidays at the gym during the daytime, sitting on a rowing machine, exercising very hard with her personal trainer just by her. And she suddenly stopped rowing, turned to her personal trainer and said, "Where am I? What day is it today? Who are you? Why am I not at school?" And she, despite being reassured by her trainer about where she was and what day it was and so forth, she continued to ask the same questions over and over again. That is, she had an anterograde amnesia, unable to take on board new information, and a retrograde amnesia. It was only for certain things she managed to call her husband on her phone, explain how she felt. She jumped in the car and drove home, and then he drove them both to hospital A&E, which is where I met her. And this syndrome lasted for about 6 hours with repetitive questioning. Otherwise, her appearance seemed to be normal. She had no other symptoms. Her language was normal. Her visual function was normal, and so forth. And the amnesic syndrome gradually resolved completely, although afterwards she had no recollection whatsoever for either having been at the gym that day or for having been taken to hospital. When I met her a few hours after recovery from her amnesia, she had no recollection of having met me earlier on in the day. So she had a dense, persistent amnestic gap specifically for those 6 hours. All her routine investigations, such as MRI scans, e.g. Blood tests, were normal, and she never had any form of recurrence of this. This is classical transient global amnesia, the defining features of which were set down by John Hodges and Charles Wallow in an article back in Brain back in 1990. And these are the diagnostic criteria, that there should be presence of an anterograde amnesia that is witnessed by an observer. There should be no clouding of consciousness or loss of personal identity, as I mentioned earlier. This is characteristic of psychogenic problems. Cognitive impairment should be limited to amnesia, not involve any other cognitive functions such as language or perception. No focal neurological or epileptic signs, no history of recent head trauma or seizures, and the symptoms should resolve within 24 hours. There are allowed to be mild vegetative, non-specific syndrome symptoms such as headache, a bit of nausea or dizziness during the acute phase. Now, it's a strikingly consistent syndrome, actually. This study by Pagu-Quinet from Brain in 2006 studied a whole load of patients, over 100 patients from France. And the key features were very consistent across patients. So the incidence is estimated to be at somewhere between 3 and 10 cases per 100,000 per year. And the classical age at presentation is about 62 years, with very few cases either in the very elderly or in the middle-aged and younger age group. The onset of the syndrome is always very abrupt, and it seems almost always to involve an anterograde and a retrograde amnesia. There is repetitive questioning, saying the same things over and over again because patients are unable to take on board new information. And afterwards, this dense amnestic gap that I described earlier on seems to persist. The duration is classically around between 1 to 10 hours long, although some recent evidence from Oxford has shown that, in fact, quite a number of cases of transient global amnesia seem to have much briefer episodes than this. But that is yet to be properly explored. But there is a suggestion that perhaps the profile of transient global amnesia that we're used to is changing a little bit, and we're understanding it can be a briefer, milder syndrome. Mild other associated symptoms are often present, such as headache and nausea, as I mentioned. And the type of triggers that lead to transient global amnesia are really striking. So physical and emotional stressors are very common. Here, in about 30%, describe an emotional stressor, such as a row or receiving bad news, or perhaps great excitement over something. And about 30% again occur with a trigger of intense physical effort, such as, for example, my primary school teacher on her rowing machine, or often other forms of exercise, or jumping into cold water. Here, water contact or temperature change is not an uncommon trigger as well. So that said, looking just in the literature, doing a PubMed search over the past 5 years for transient global amnesia, one can find a whole host of different things that seem to be attributed as the trigger of an episode of transient global amnesia, typically in case reports, single case reports. Some of those things being intracranial pathologies, so cerebrovascular episodes, infarcts in various parts of the brain, dural AV fistula, cerebral venous sinus thrombosis, and so forth. But there are also things which are extracranial that seem to be associated with transient sudden onset amnestic syndrome, cardiac problems, renal problems, aortic dissection, nephrolithiasis, marijuana use, a whole range of different potential triggers. So what it seems is that, at least to some extent, TGA can be a final common pathway of a whole variety of different shocks or triggers rather than being a sort of standalone entity by itself. But this is really not clear, and there have been a number of hypothesized etiologies for TGA over the years, including epilepsy, which was an early favorite, and in fact a small proportion, about 5 or 6% of patients described in the early series of TGA did go on to develop epilepsy, and I'll talk about those in a moment. But in the vast majority of cases, as I mentioned, recurrence is very rare. Migraine was a favorite hypothesis as well at some stage. Again, not really clear why the TGA recurs at so infrequently, if this were the case, and also why it should occur mainly in older people. Cerebrovascular disease is also has been a favored hypothesis, but in fact, large studies of patients with TGA have revealed no increased risk of cardiovascular problems, no increase in white matter abnormalities on MR imaging, and no increased risk for subsequent stroke. So that seems to be unlikely, at least that there is arterial pathology underlying TGA. Jugular venous insufficiency was an interesting proposal from Lewis in 1990, largely based on the fact that quite a proportion of patients with TGA had their episodes precipitated by a Valsalva-like maneuver, breath holding and type of maneuver, picking up something very heavy, for example. And indeed, in some relatively large series of patients with TGA, it has been found that the jugular vein is insufficient at a much greater rate in these patients than it is in healthy controls. Indeed, in the study by Cejas and colleagues from Stroke in 2010, who looked at, I think, 150 odd patients with TGA, they found that 80% had jugular insufficiency compared to healthy controls who just had 25%. But oddly, subsequent studies with MRI have failed to show any intracranial effects of this, and how this in fact should play out in terms of causing an amnestic syndrome is far from clear. So whether or not it is indeed causative for TGA remains to be proven. For many years, it was thought that there were no imaging correlates of TGA, but just over the past 15 odd years, it has been demonstrated using newer techniques such as diffusion weighted imaging that there are punctate abnormalities, changes in diffusion weighted imaging in patients with TGA in the hippocampus, in the CA1 subfield of the hippocampus, and that these appear about 12 to 72 hours after the onset of TGA and then resolve spontaneously. Now, the literature's quite varied about how frequently these occur in TGA. Anywhere between 20 and 80% of patients seem to have them, and what they actually represent again is unclear, because they do seem to resolve over time. But anyway, this is a clear-cut indication that there is a focal problem with a particular region of the hippocampus during the acute episode of TGA. Now, what about its long-term prognosis? Well, a large cohort from the Mayo Clinic of 221 patients between 1985 and 2010 was published in 2017 here. And they were matched against 221 controls, healthy controls, to look at long-term follow-up. The populations were largely matched in terms of other illnesses. There was a slightly increased risk of diabetes in controls compared to patients, and there was a slightly higher rate of migraine in TGA patients compared to controls, although the background rate in controls was surprisingly low at just 5.4%. So I'm not sure exactly what that means, but that holds up along with other literature on TGA showing a higher rate of migraine. But as they followed these patients up over up to 30 years in some cases from baseline, there was no difference in the Kaplan-Meier survival curves between patients and the healthy controls in time to cerebrovascular event, time to seizures, time to cognitive impairment, and so forth. So the prognosis long-term appears to be very good. There are, it should be said, just a few cases which very much look like TGA, which turn out, in fact, to have been stroke. This was a paper published in Stroke by 2017, where they looked at almost 4,000 cases of stroke and found that just 0.2% of them presented with focal amnesia. And in fact, of those 13 cases, 9 of them were a very classical transient amnesia type of syndrome lasting just about 5 hours. So these cases were largely posterior circulation strokes, and quite a number of them had persistent memory problems on testing. So this indicates that although rare, there is probably good reason to perform acute imaging in patients who have TGA. So an interim summary for transient global amnesia. It usually consists of a single sudden onset episode of amnesia with repetitive questioning, duration typically of 4 to 12 hours, but sometimes less than that now, often triggered by physical or emotional stress. These hippocampal lesions are present for a short period after the amnesic episode on diffusion-weighted imaging. The etiology remains unclear, but the prognosis is good, and recurrence is very rare. Now, that rareness of recurrence contrasts with the case that I'm about to describe of a patient of mine, JM, who I met several years ago now, who was a 63-year-old carpet fitter. Now, he woke in the middle of the night, one night, just a few days after his brother had tragically died quite young. He woke in the night and went downstairs to the lounge, and then came back to the bedroom a few minutes later in a sort of state of some considerable distress, and woke his wife saying, "Something terrible has happened. I'm not sure what. Why is the lounge downstairs full of cards and flowers?" His wife woke and looked at him surprised and said, "Your brother's just died. What do you mean?" And he had no recollection of the fact that his brother had just died and was very distressed by this. And then just a few minutes later, it turned out that he again had no recollection that his brother had just died. And his wife needed to keep reminding him. And every time he heard about this, it was equally distressing for him. He, in fact, had no recollection of anything that had happened over the last few days. This, otherwise, from the memory loss, seemed to be an isolated problem with amnesia. His language, his appearance, and everything else about him seemed to be normal. And the amnesia resolved after about 45 minutes to an hour. When they saw the doctor the next day and told him about it, the doctor said, I shouldn't worry too much. This has obviously been a period of incredible stress and anxiety for you. It's probably due to that, and it's very unlikely to happen again. Strikingly, it did happen again. In fact, it occurred about 20 times over the subsequent 2 years, and always with this characteristic pattern that he would wake in the night or in the morning, or sometimes he would wake after a sort of an afternoon nap and be amnestic for the last few days and be unable to take on board new information. Now, in between attacks, he was pretty normal, but he did complain that there were some persistent problems with his memory. So, for example, I said he was a carpet fitter. He went to fit a carpet for a friend of his, and a couple of days later, he sent him the invoice for that work that he had done. So he clearly remembered having fitted the carpet. But then 2 or 3 weeks later, he went to see his friend for a cup of tea and noticed he had a new carpet laid. And he said to his friend, "You've had a new carpet fitted. Why didn't you ask me to do it?" And it turned out that although he had initially remembered that the job of fitting the carpet, a few weeks later, he had no recollection of having done it. On another occasion, he went with one of his sons to watch a film at the cinema and discussed it with his wife later on that evening. And then a week later, he saw his son again, and his son sort of referred back to the film that they had seen, and he had no recollection of having seen the film before. So he has this syndrome of accelerated long-term forgetting, whereby memories are initially intact and then they gradually fade. And this was despite the fact he had not had any of these transient amnestic episodes in the meantime. He also seemed to lose memories for things that had happened many years ago. So autobiographical incidents, things from the remote past, his own wedding, honeymoon, holidays that he'd been on with his family many years ago seemed to disappear, whereas memory for day-to-day things seemed to be fine. And finally, he had problems with remembering his way around, despite having lived where he'd lived in Glasgow for most of his life. He was having difficulty finding his way around the shops and other places, which he'd never had problems with before. So he had these acute episodes of amnesia, which were brief, and in between the episodes, he had some strikingly unusual difficulties with his memory. Eventually, it became clear that he had a form of epilepsy. So in fact, he developed olfactory hallucinations alongside these transient amnesic episodes, and the EEG showed epileptiform activity in the temporal lobes bilaterally. And he was started on lamotrigine, and the episodes ceased completely. That was the diagnosis of transient epileptic amnesia, very similar to transient global amnesia in many ways, but in other ways strikingly different. Despite the treatment, however, these persistent memory problems, the accelerated long-term forgetting, the autobiographical amnesia, and the topographical amnesia, or the spatial memory problems, persisted. So we went on to study a large group of patients who had similar clinical features. We studied about 50 of them initially. We've now seen getting on for 150, I should think. The diagnostic criteria for transient epileptic amnesia, or TEA, are that you should have recurrent witnessed episodes of transient amnesia during which other cognitive functions are intact, and there should be evidence of epilepsy from one of or more of 3 sources. So either epileptiform abnormalities on the EEG, other clinical features of epilepsy, such as olfactory hallucinations or automatisms or other features that we sometimes see, and a clear-cut response to anticonvulsant medication. So in our cohort, the age of onset of these symptoms is actually very strikingly similar to that of TGA, transient global amnesia, about 62 years mean, and a range between 44 and 77. Frequency is much more common than TGA, so often about monthly attacks, although clearly this can vary quite a lot. The attack duration is much briefer than classically understood for TGA. So often attacks last up to about half an hour, although there are some longer lasting attacks. So just because you have persistent amnesia over several hours doesn't mean you can't have TEA. Very interestingly, this feature that I talked about with patient JM of occurring upon wakening from sleep is quite common. So at least 3/4 of patients have some attacks on waking from sleep, and about 1/4 of them only ever have them in that context. A good half of our patients have an incomplete anterograde amnesia, and I think this is a helpful clue. So after the attack has resolved, patients with TEA are often able to remember not having been able to remember. So they're able to remember things that occurred during the episode, which is uncommon in TGA. Olfactory hallucinations are also pretty common, occurring in almost 50%, and that's much more frequent than in classical temporal lobe epilepsy. Generally, there's a very good response to anticonvulsant medication, and we observed complete cessation of seizures on a single agent in about 9 out of 10 patients, and the others improved greatly with a single medication. But nevertheless, 3/4 of patients, despite the cessation of their attacks, described these ongoing memory difficulties, as I mentioned with patient JM. So we went on to look at these, the sort of interictal neuropsychology of TEA in more detail, and we compared our 50 patients with TEA with a group of 24 healthy controls who were matched for age and education. And in fact, they did very well on a whole range of non-memory neuropsychological tests of language, executive function, and perception. Now, there were some subtle deficits in standard tests of anterograde memory, story recall, word recognition, face recognition, particularly these ones down the bottom where the p-values are less than 0.05. But the deficits are very subtle, less than 1 standard deviation in most cases, and with no one falling within the impaired range according to the sort of population norms. Now, we have some evidence that TEA is due to focal seizure activity in the medial temporal lobes. There's not much evidence because it's difficult to catch these patients during the attacks themselves, but this is an FDG PET scan from one patient who had a prolonged episode of TEA that lasted several days, and he went into a PET scanner during them and had this very high, strikingly focal hypermetabolism in the left hippocampus that then resolved 3 months later. We think that the amnesia may be either an ictal phenomenon or possibly a post-ictal phenomenon in some cases, and there's evidence for both in the literature. And we assume that there must be bilateral spread of the ictal activity from one hippocampus to the other without involving other parts of the brain, because just affecting one or other hippocampus typically doesn't lead to the amnestic syndrome in other conditions. You have to take both hippocampi out for there to be a dense amnesia. If we look at MRI scans from a group of patients with TEA compared with healthy controls, there is subtle hippocampal atrophy and also perirhinal atrophy. This is a region of the brain just nearby the hippocampus here in the medial temporal lobes. But again, this is relatively subtle. It's just down by about 8% in volume. And this is accompanied also by some subtle atrophy in the orbitofrontal cortex. But otherwise, the rest of the brain appears to be normal in volume. Okay, so looking a little bit more at the interictal memory deficits in a group of patients, we showed that they do in fact have this relatively normal ability to learn new information and to recall it over a shorter period of time, about 30 minutes. So relatively normal performance on standard anterograde memory tests. This is interictally, but dramatic fall off in memory over longer periods, such as a week or 3 weeks compared to healthy controls. This is accelerated long-term forgetting and may well be a deficit with that process I described earlier on of memory consolidation, rather than with the acquisition of new memories. And indeed, one can demonstrate also this loss of autobiographical memories from the remote past in TEA patients, here shown in white, compared with healthy controls in grey. These are recently acquired memories from middle age, young adulthood, youth, and childhood. We can see that there are deficits in patients across all epochs of the life for autobiographical memories. And that's striking, especially when you consider the model of memory consolidation that I mentioned earlier, that these very remote memories are not considered to be dependent on the hippocampus. This suggests that TEA affects a memory network beyond the hippocampus, perhaps through spread of ictal activity throughout that network, in a way that just purely focal damage to the hippocampus without epilepsy may not cause such remote deficits. But the reason for this strikingly pervasive and extensive autobiographical amnesia in patients with TEA is not yet clear. just mention about the prognosis of TEA. We have followed up quite a number of patients now over a long period of time. For example, here in a paper we published a couple of years ago in Seizure, there were 10 patients who we followed up over 20 years and 42 patients who we followed up over 10 years. There has been some concern that maybe this is an early feature of neurodegenerative disease such as Alzheimer's disease, but in fact we found in our smaller cohort of 10 patients no Alzheimer's disease cases after 20 years follow-up, and just 4 cases in the larger group over 10 years, and that is very much in keeping with the background Alzheimer's disease prevalence of about 7.7% estimated in the population of this type of age. So no evidence of increased risk of Alzheimer's disease in long-term follow-up, which is very reassuring to tell patients about. And also the vast majority had very good ongoing long-term control of seizures. So just before I wrap up, I'd like to just tell you briefly about another feature of TEA, which has become apparent by talking to patients and isn't necessarily related directly to the memory loss. And that's something which we've called pathological emotionalism. And we've just conducted a study of this, actually not in TEA, but in limbic encephalitis patients, a group of limbic encephalitis patients who show similar features and in whom we've got some interesting findings from neuroimaging, which I'll describe. But I think that the clinical syndrome seems to be strikingly similar. And what patients describe is that they are more readily provoked to tears than they used to be prior to having TEA. And not necessarily by particularly emotional stimuli. Perhaps just, so a common thing they may say is that just watching the news and seeing something happening in the world to someone completely unknown to them may provoke them to quite marked and prolonged tearfulness, or hearing some bad news about someone that they don't even know, and they'll say things like, since diagnosis I feel far more emotional within myself, or I've turned into a bit of a wimp, overwhelmed by emotion. That happens in our TEA group, whom we asked 26 of them, and 24 reported this. Other emotions seem to be okay, so there was no increase in laughter or happiness or in fear as far as we're aware. Some patients described slight increase in irritability. And the sorts of things, as I say, that they described as triggers: watching films, especially things like Disney movies or old classics, seeing cruelty to animals on television, certain pieces of music triggering this, watching a sad story on the news, as I said earlier on. So we know that the limbic system, the hippocampus and other associated regions, are involved in emotional processing. So this may be part of the reason why this occurs. It's strange that it hasn't really been described before. It seems to be some way, to some extent, related to the syndrome of pseudobulbar affect, which has been described in a number of conditions such as motor neuron disease, stroke, multiple sclerosis in particular. But that is different in that you also have pathological laughter with pseudobulbar affect. The episodes of laughing and crying in that are often untriggered, and it's often incongruent with the emotional state of the patient themselves, and that seems to be different from what our patients are describing. We sent out a questionnaire to a group of patients with limbic encephalitis. This questionnaire, called the Center for Neurologic Study Lability Scale, CNSLS. It's just simple 7 questions relating to laughter and crying, and we found that our patients describe very dramatic problem with labile crying and not with labile laughing when you compare them both with healthy controls and with patients who've had autoimmune limbic encephalitis but don't describe this pathological tearfulness. So this questionnaire does seem to be picking up what patients describe. There was no relationship of this syndrome or this symptom with underlying scores on of depression or anxiety on, for example, the hospital anxiety and depression scale. So it doesn't seem to reflect their underlying mood at all. There's no relationship with their scores on memory tests or on executive function tests or on a questionnaire to do with impulsivity, which one might imagine impulsivity or disinhibition to be related to this. So no clear-cut relation to any other psychological, psychiatric or cognitive features. And exactly half of our 36 patient cohorts, so that's 19 patients, described this feature and the other half did not. So we were able to directly compare those two groups and to look at their brain imaging. And in fact, we found that those who describe pathological tearfulness show a very focal loss of volume compared to those who don't describe it in the anterior hippocampus, anterior right hippocampus, in the cerebellum, and in a couple of other small brain regions, which I'll describe in a moment. And there's a very interesting and strong correlation between, for example, the right anterior hippocampus and their score on this questionnaire, the CNSLS. So although these patients have a very similar memory function, the hippocampal volume seems to be lower in those who have pathological tearfulness. And this goes back to a bit of a literature on the hippocampus and mood, which is not that well explored in neurological patients and will be the focus of more studies from us soon. Interestingly, there are abnormalities in the connectivity of the hippocampus with other brain regions in patients with pathological tearfulness that correlate with their symptoms. So the hippocampus seems to be less well connected, particularly to this region here of the posterior cingulate cortex, which we know is important for a variety of self and other related processing. So perspective taking, being able to appreciate the context of emotional and other states in the world. And finally, we find some very interesting abnormalities in our patients who have this type of symptom of pathological tearfulness in more motor regions subcortically. So in the cerebellum, particularly in these regions of the cerebellum across 1 and lobule 6, where we know that strokes and other pathology can also trigger emotional incontinence or pathological tearfulness, as well as an abnormality here in the ventral pons, which again, there are a couple of case reports in the literature of patients with stroke here who have a similar loss of control of emotional expression. So there's some very interesting findings relating to this novel syndrome. This has just been published in neurology in this group of patients with limbic encephalitis, but we're going to go on and look at it in TEA patients as well. And we probably expect to find similar neuroanatomical abnormalities, and we want to explore why it's happening, of course, mainly as a means to be able to go on and treat it in patients who find this symptom particularly distressing. And I would encourage all of you to ask your patients about this symptom, because often I think it is misdiagnosed, underdiagnosed, just not diagnosed at all. Often people think that they're either going mad or that they're depressed or something, and it's important that we recognize it so that people can cope with it. Okay, so to wrap up, I have talked about 3 common syndromes of transient amnesia: psychogenic amnesia, fugue, focal retrograde amnesia, then transient global amnesia, perhaps the best well-known of all of these, and transient epileptic amnesia, where there is much more recurrence of the episodes, they're briefer, and they respond to anti-epileptic therapy. I've gone on to talk a bit about some of the persistent, that is the non-transient cognitive and behavioral deficits, particularly associated with transient epileptic amnesia, and shown a close interaction between memory and emotion, both in all three of these syndromes: psychogenic amnesia patients, the transient global amnesia patients who have the onset of this, often with emotional stressors, and in TEA patients who have this persistent problem with emotional regulation. So with that, I'd like again to thank the organisers, to the fine organisation, for the opportunity to talk to you today, and also to people from my research group and my collaborators and my funders who have enabled some of much of the research. Thank you.
Hi, Chris, that was a wonderful talk.
Yeah.
Very interesting. We see transient global amnesia off and on, transient epileptic amnesia only rarely. And I think we have diagnosed it only when the person gets actually a seizure later on. Do you think that person might be getting a seizure partial in sleep and then he wakes up post-ictal? What do you think?
So yeah, thank you very much for that question, Sudhir. That's a very, very nice question, and it's something we often ask ourselves, and I think that is indeed the case. So there are certainly a number of cases I've seen where the sleeping partner, the wife or husband of the patient, says that during sleep, during the night, they've heard or seen their husband or wife making sort of funny movements during sleep, either sort of grunting movements or licking their lips or something like that. They haven't woken up. They've not, there's not been any dramatic shaking movements or anything like that. Just a slight sort of chewing sensation. And then in the morning, often several hours later, when they wake up in the morning, that's when the amnesia is present. So I think certainly in a proportion of cases that is possible, that they've had subtle temporal lobe seizures during sleep that haven't been otherwise manifest. And then there's a rather persistent sort of a bit like a Todd's paresis of memory, if you like, that becomes apparent only when they wake up. So that's a sort of a post-ictal form of transient epileptic amnesia. And I think, although that said, I think that there are other cases documented in the literature, with electroencephalography, showing that during the sleep the patient is normal. There's not been any epileptic activity, and the epileptic activity is triggered upon wakening. So I think the two things can happen. But I certainly think that subtle seizures, which aren't picked up either by the patient or by their relative, and often even not by the neurologist when the patient turns up to clinic, can be the cause of profound memory deficits of the sort that I described in TEA. So this accelerated long-term forgetting, or the autobiographical memory loss. Sometimes I've had patients coming to clinic whose primary complaint has been those interictal memory, those sorts of persistent memory problems, loss of memory for holidays they went on many years ago, for example, which are completely atypical of things like Alzheimer's disease or other sorts of memory problems that we often see. So, and those patients haven't described to anyone any, significant seizure episodes, either amnestic seizures or other types of seizures. And it's only on deeper specific questioning that subtle things like déjà vu or unexplained panic attacks come to the fore. And in fact, it's the persistent memory deficits that are revealing the fact that the patient has epilepsy.
This is also very interesting why in transient global amnesia the trigger is often, one of my patients was in the Middle East and he jumped off a boat to swim in hot sun and swam across to an island, and when he reached there he couldn't remember what he had an attack of seizure. So it was a combination of cold water plus exertion of suddenly swimming. So do you think this trigger of emotional or physical stress seems to favor migraine? Because there's no reason why that should cause a stroke or why that should cause a seizure.
Yeah, that's right. So I mean, what's going on at a sort of neurochemical level is not clear, but certainly this phenomenon, the cortical spreading depression of Lau, that is sometimes held to underpin at least the aura of migraines, slow wave of depolarization of the cerebral cortex that seems to occur at the onset of migraine, has been postulated as a phenomenon in TGA. But not proven. And why that should relate to an acute emotional trigger or a physical trigger is very much unclear. There are a few theories out there, but there's really very little proof.
Okay, Rahul, you can take the questions.
Yeah. One question, which is, what should be my explanation to the patient and family of the patient with transient global amnesia, that why such a thing happened? Is prescribing aspirin and statin correct? What all investigations should be carried out for such a patient?
So I'm very sorry, but the line is very bad, and I'm afraid I failed to hear the question. Could you just repeat it in one or two sentences?
Yes.
Am I audible?
No, the sound had got. Rahul, please repeat because it was not coming properly. Okay, I think he's not coming. I'll explain. I'll repeat the question. Somebody is asking, what should be my explanation to the patient and the
what should be the explanation to the patient or relatives of patient of transient global amnesia?
Transient global amnesia.
Yeah, and do you giving aspirin and statin, is that correct? Plus, thirdly, what investigations are a must?
Okay, so I think the most important thing from the relatives and the patient's perspective is that the prognosis is very good, that there's no evidence of risk for future stroke, that there's no evidence of risk for future Alzheimer's disease increased above the background population, and that recurrence is very unlikely, and also that if recurrence does occur, particularly if it occurs on several occasions, they should not ignore it, but they should seek help, because of course this may turn out to be an epileptic phenomenon rather than TGA. So that's the most important thing to stress. Now, in terms of what you do as investigations for these patients, I think the story is possibly slightly different from how it used to be. So people really did recommend no clinical investigations at all, really, for patients with a classical TGA syndrome. I now certainly am doing MRI scanning, and if you don't have MRI, then CT scanning I think is important, within a day or two of the onset, because of this admittedly small but important proportion that do have a posterior circulation infarct. So I think that CT at least is imperative now, although the yield will be low. Would I do an EEG? So I wouldn't do an EEG if there are no indications that this is an epileptic abnormality rather than classical TGA. So with a classical TGA syndrome, I wouldn't bother doing an EEG. There are so many false positives and false negatives with EEG. So yeah, that's probably all I would end up doing, and some routine bloods. If there's anything untoward about it, about the TGA syndrome, if it's shorter than I might expect, or if there are any sort of focal neurological abnormalities, then of course investigation should be more thorough.
Would you give aspirin and statin?
No.
You've already shown that in the long run, then there is no increased risk of stroke.
That's right.
You want to try again? The sound was getting broken.
So no, I wouldn't recommend giving aspirin or statin. No, absolutely not. There's no need. Yeah.
So you want to take the next question?
Yes, please. I'm very happy to take the next question.
I think his signal is okay. So somebody is asking, does loss of personal identity differentiate between psychogenic amnesia and transient global amnesia? And then the same person is asking, in TGA, patient asks, who am I and where am I? So isn't that a loss of personal identity? But they don't ask who I am.
So no, not in my experience. Sorry, can you hear me, Dr.
Yes,
Katari?
yes.
So in my experience, they don't ask who am I. No, I wouldn't say that's the case. I've never seen that actually. I mean, that's having said that, that may be there may be cultural differences. Sorry. There may be cultural differences in the way that people express their loss of memory, describe their loss of memory, and indeed react to the emotional circumstance of having lost their memory. So it may be that people feel like they don't know who they are because they can't remember things. So I guess that's true. I don't think that within the context of the United Kingdom that I've ever encountered people saying that they don't know who they are, as in what their name is, or those sorts of very profound things about personal identity in TGA. So I do think true loss of knowing who you are, failure to recognize close family members, that doesn't occur in TGA, and it's very suggestive of a psychogenic amnesic syndrome. Yeah.
Yes, it doesn't happen here also. They do not usually ask who am I. They will ask about something that happened or why they came somewhere. They know where they have come, but they may forget why they had come or things like that.
Yeah.
Then somebody is asking, is it really global amnesia or is it focal and selective amnesia?
Yeah, good question. It's an old term, isn't it? It's from 1964 when the term was first properly coined. The global, I'm not really sure. I can't, I've never been quite able to work out whether they mean here that the global is to do with every type of memory being affected. I think rather not. It's more about the fact that it's both anterograde and retrograde memory that is lost. But I agree that the vast majority, depending on how you define memory, the vast majority of sort of memory systems are intact in
What
TGA.
about verbal memory and non-verbal memory? Is there a difference between showing pictures and objects, checking that? And similarly, the MRI abnormalities are seen on one side. So are there two types of TGA, whether it's the right side, which is showing that diffusion abnormality, or the left medial temporal lobe?
Okay, great question. The difference between verbal and non-verbal memory is subtle, if there is anything. Okay, it's possible that there's a slight worsening of verbal memory compared with non-verbal memory, but really the deficit is generally present for both. It's although this punctate lesion in the hippocampus can be unilateral, it's I think very, very frequently bilateral. And just because there is this punctate lesion that you can see on DWI, it doesn't mean that that's the only thing that's going wrong with the brain. We know that if you put people, in a PET scanner or do fMRI on patients who are in the middle of a TGA attack, there are widespread changes in the functional activity in the brain. Obviously in the medial temporal lobes bilaterally, but also in frontal regions and in posterior medial regions as well. So it isn't just a focal disorder. There are, abnormalities of brain connectivity and brain function throughout a wide memory network. And it's not a unilateral condition. So although you may see these abnormalities sometimes just on one side, sometimes you don't see them at all and the patient's still densely amnesic. So I don't think they are the only and pure pathology. That's just the only thing that we can detect using using standard sequences in clinical practice.
Rahul, you want to try stopping your video and seeing whether the sound improves?
Me?
No, Dr. Baris.
Sound internet connectivity does
No, no. Okay. Okay. Then, Chris, there are some questions. Is there any treatment required for transient global
Just
amnesia?
try my stop.
Do you require any treatment?
Sorry, Dr. Kutari, I'm having some
Sorry,
problems with the sound.
I think. Okay. Can you hear me now?
I can hear you now.
Does TGA require any treatment?
In terms of medical treatment, no, not at all.
Probably you just have to ask somebody to stay around until the person becomes all right.
So absolutely. I mean, I think that you know, you need to watch people, you need to investigate people, as I've said, and often, you know, they're not during the throes of the acute phase of an amnestic attack. They are not able to look after themselves properly, so they need to be either carefully looked after at home or kept in hospital overnight or something like that. I think that's entirely appropriate. But in terms of, you know, giving acute aspirin or anything else, I think that's not necessary unless in the few, you know, rare cases where we see an abnormality on the CT scan, but that is, you know, very much less than 1% of patients.
Okay. There are a couple of questions on TEA. So somebody is asking, why is it more common on waking up? And if you do select an AED, is there any particular choice of AED? Dr. Manjula asked this. So
yeah, so, well, you know, the answers to that are, well, the first question, why does it occur on awakening? So the transition between, well, so there are clear-cut relationships between different sleep stages and epilepsy, temporal epilepsy in particular, anyway. I don't know why TEA itself should be particularly related to sleep compared with other forms of epilepsy. That I can't say, and I can only imagine that it's something to do with, you know, the electrophysiology of the hippocampus, but that has not been studied. So obviously our patients with TEA don't have intracranial electrode recordings or anything like that that would enable us to look at the networks during sleep or during the attack themselves. So I can't answer that question, except to say that we know that different sleep stages, particularly slow wave sleep, and particularly the transition between sleep and wakening, are common triggers for seizures in people who have underlying epilepsy anyway. Okay. Why that should be particularly specific to TEA, I'm not sure. And with regard to anti-epileptic drugs, you know, no, except just to say that the obvious, that these patients are generally older people, and so therefore your choice of anti-epileptic medication will go along with that increase in age, and therefore you'll, you know, be aware of the various other medications that they may be on and interactions with those. So, you know, lamotrigine is an obvious choice in patients, given its slightly more favorable side effect profile. And, you know, the fact that it needs to be titrated up over a longer period of time is not generally a problem because the seizures are relatively infrequent and minor.
Right. Okay. Then Dr. Rawat, who's an epileptologist, she's asking, did your patients of TEA have any automatisms of the hand or oral automatisms? And did you find any particular EEG abnormality in the TEA patients?
Okay, great. So yes, automatisms are not that infrequent. If I recall correctly, something like 25% of our patients have automatisms, and typically not of the hand, and typically it is of the orobuccal muscles. So, you know, lip smacking and chewing motions are not that infrequent. Either, as I mentioned earlier, preceding the amnestic attack, during sleep, or during the amnestic attack itself, even, you know, whilst they're awake. So that's not an uncommon feature, perhaps a quarter to a third of patients. And the other question was about the EEG findings. So the important thing to say here is that sleep-deprived EEG is much better at detecting interictal epileptiform abnormalities in TEA than routine EEG. So routine EEG is very often normal. You know, the epileptic focus is deep inside the brain, and you know, we don't think that the discharges are likely to spread much beyond the medial temporal lobes, or otherwise, you know, patients would have other types of semiology during their seizures. So it's not unsurprising that surface EEG is normal in a lot of patients. Now, with sleep deprivation, we tend to get about 30 to 40% positive EEG in TEA cases. So again, you know, sort of bond or normal for transient for temporal lobe epilepsy sort of rates. And, you know, obviously it's always or almost always frontotemporal activity, and, you know, not infrequently bilateral, but not favoring one side or the other.
You've already answered that the prognosis is good, and in the long run, there's no risk of Alzheimer's or any autoimmune disorder or stroke. So we'll drop that question.
So I would just say there, sorry, I didn't mention about autoimmunity and TEA. So I have, we've published a few cases where transient epileptic amnesia has been the presenting feature of autoimmune limbic encephalitis, with a variety of different antibodies. So with LGI1, with NMDA receptor antibodies, so it's not even a limbic encephalitis, and with anti-GAD antibodies. So yeah, there are a few rare cases where there's a thought that there is an underlying autoimmune condition driving it, but that is pretty rare, and I wouldn't recommend doing those tests in everybody, basically just if the seizures are difficult to treat with anti-epileptic medication, because as we know, the seizures in autoimmune limbic encephalitis or related conditions are more difficult to treat with anticonvulsants, and immunotherapy is often necessary. Okay,
Dr. Singhal asks, can you get transient amnesia in migraine?
Thank you, Dr. Singhal. That's a lovely question as well. So there, it's you know, I should get around to writing this paper one day. There certainly are cases of migraine-associated transient amnesia, and you know, maybe they're the same as transient global amnesia, but I'm not sure that's always the case, because you know, there are certainly patients who have very, very, very striking migraine-associated amnesia. Now, it's really rare. I've probably seen 2 or 3 cases, and there are some out there in the literature. Maybe you've seen some yourself. But you know, definitely an interesting thing to be followed up on. I wouldn't be able to tell you how, you know, how they compared clinically with TGA or TEA in terms of prognosis, or in terms of you know, their clinical syndrome, besides the fact that, you know, when it happens, it's sort of obvious because they're sick and they've got a blinding headache at the same time. But yes, I think migraine and TGA overlap to some extent.
There is always some degree of cognitive impairment during a migraine attack, but there used to be a term called dysphenic migraine, DYSPHRENIC, in which you get a lot of cognitive impairment as the presentation of migraine. I don't know what has happened to that term now, but was there when I was studying, so I don't know.
Yeah, you're right. You're right. I don't know what's happened to it either. I'm sorry, I should look it up. But I definitely come across that, yeah.
Then Dr. Somarajan asks, can hypoglycemia present like TEA or TGA? Hypoglycemia.
Okay. Yeah. So I didn't really cover this. I should have done, and I'm sorry. There are, you know, a bunch of other causes of transient amnesia which are really poorly defined and which haven't been studied properly. So migraine is one of them, and hypoglycemia is undoubtedly another. Yes, absolutely. but again, just case reports, a handful of case reports, and I think I've seen one or two. And of course, we should bear in mind that profound hypoglycemia can also cause, a permanent focal damage to medial temporal lobe structures, particularly the hippocampus. And I've seen a couple of patients who have been brought in after profound and prolonged hypoglycemia who've ended up with, very dense high signal in the hippocampus bilaterally and a persistent amnestic syndrome. So yes, but again, not well understood at all.
You mentioned drugs, sildenafil. I think I didn't see short-acting benzodiazepines, because that some people used to take these before an transcontinental flight, and then they would land up in New York and not know why they came. So short-acting triazolam and those can cause.
I absolutely agree, and I have a slide which I should have included with all these other things, and benzodiazepines of course is there, and of course alcohol is there as well. So and another thing, another one that may interest the audience is something which is been described as fatigue amnesia. So described in a lovely article by Adam Zeman in Cortex a couple of years ago amongst junior doctors who, in the olden days, probably, I'm not sure whether this is still the case in India, but doing, very, very long shifts lasting often, 72 hours without very much sleep. And some nice reports from doctors of having, done things like led arrest calls in the middle of the night and written in the patient's notes, and then got up the next morning and gone back to the ward with no recollection whatsoever of having conducted those episodes of care, presumably due to extreme fatigue. So, that's another one that maybe some members of the audience may relate to personally.
In the middle of the night, getting woken up and advising therapy, I have myself done that, and next day morning, I don't know, I told it, but I have told the proper treatment, that is the saving grace.
That's right. Yeah, absolutely.
Dr. Pasi is asking you, we'll take the last one or two questions. Dr. Pasi asks, have you examined any patient during an attack of TGA? I think we do.
Have I examined a patient during TGA?
Yes.
Yes, I have. Yes, I have. And I have some video, which I was going to show, but I didn't want it to go up on YouTube. So I didn't show it. But yes, absolutely. I've seen a number of them. Is there a specific question relating to that?
Yes, Dr. Singhal asks one more. Often the family members report about occurrence of TGA rather than the person himself seen during the TGA. Is that, do you see the family person reporting that this happened? Instead of the patient actually coming to the hospital, you may get a history that they said that the person was repeatedly asking questions, was looking confused.
Absolutely, of course, yes. Often it doesn't come to the hospital. I should imagine, particularly in patients who are very isolated and far from acute medical services, but also in patients who have had one or two attacks in the past, and they just go, oh, it's that happening again. So absolutely, and the patient may well not remember anything about it when they come round and not have any recollection of there having been anything abnormal. So it's not surprising at all that the patient's relatives should be the ones who flag it up. Yeah.
We will take the last question. Dr. Nadir Barucha, senior neurologist, he is asking, is pathological tearfulness due to excessive feeling of emotion, say due to higher empathy levels, or is it an inability to block the expression? And could there be differences?
That's a really nice question. Thank you. And it's something that I often think about, and that I'm currently writing a grant application to try and answer. But I think it's probably, so what can I can't tell you because it hasn't been looked at systematically, but it should be possible to answer that question with proper experimental methods. Just talking to patients, one gets the feeling that it's both. So in some patients, one more than the other. So certainly a number of patients do say that I empathize more with other people, that I'm feeling other people's emotions or whatever during this episode than I ever used to. So some people say that there's an increase in empathy. And that would potentially go along with these abnormalities we found in the brain in the posterior cingulate cortex, or these posterior medial cortices, which we know are relevant to, as I said, perspective taking and empathy and things like that. On the other hand, other patients, and seem to say much more that it's like some sort of just a reflex that they can't control. They're not really feeling sad. It's just a lump comes to their throat, the tears come to their eyes, and they just can't help it. And there doesn't seem to be any cognition involved in it at all. And in those cases, one wonders whether it's the more brainstem cerebellar elements of the system, the emotional control system, that are going wrong. It's a much more subconscious level of discontrol. So I think that that's a great question, that from a sort of neuroscience, understanding the mechanisms of how we regulate our own emotional expressions is important to try and address and to answer, and we'll hope to be doing that. But just from talking to patients themselves, I get the feeling that probably a little bit of both is included.
Okay, this doesn't relate to the memory. I wanted to ask one last question. In pseudobulbar palsy, I had a feeling that the person may laugh or may cry, but actually he doesn't feel happy when he's laughing, or he's not feeling unhappy when he's crying. So there seems to be a disconnect between what he's doing and his feelings. While these patients that you are describing, probably they feel empathy, they feel sad.
Good. Yeah, that's right. That's the key difference, I think. That's what we are. That's what we believe, and that's what we think is the main difference between us and pseudobulbar.
How do SSRIs work in pseudobulbar palsy? We often give fluoxetine for pseudobulbar palsy. How does that work then, if it's not acting as an antidepressant?
Gosh, who knows? I mean, we don't know, do we? So in my experience, fluoxetine is not that great for pseudobulbar affect, actually. But maybe I haven't seen a lot of it. I certainly wouldn't be able to postulate the underlying mechanisms of why it works in some patients. But there's an open question about whether it works better, and I wouldn't be surprised if it does work better in the syndrome that we're describing of pathological emotionalism, pathological tearfulness. I wouldn't be surprised if it works a bit better, even though it's not related to mood. It does at least feel a bit more of a cognitive symptom.
Okay, Chris, thank you. It was an excellent session. Enjoyed the question answer. Rahul, can you, is your voice come back? Yes, I think no, his voice is not coming. Wait.
Okay.
Thank you, Chris. That was a very scintillating session, and we'll call you back again sometime when you have time and we also have time like this. Thanks a lot.
Well, listen, thank you very much indeed for the invitation. It was a real delight to be able to speak with you, and I enjoyed the conversation.
We won't forget. This is one session we won't forget for sure.
Okay, very good. Thank you very much indeed. All the best. Bye-bye. Thank you.